Be telling you today is what was it like when I first started forensics, which is in August 1990? What is it like now, and where do I think we should be going? When I started in 1990, we had a psychometrician who was a conscientious objector, and he did aways on every single observation case. And in those days, if someone scored an IQ below 60 and 65, they were certified as a state patient. Their level of functioning was not considered. Cultural, educational, socioeconomic issues were actually ignored. So there were two consequences to this, really. The first is that ultimately many were discovered to actually to be quite high functioning. They were not ID. Second of all of them, because they had the level of ID, were becalmed in the system with little hope of discharge. So if they were young and they'd committed, say, a sexual offense or whatever it is, their chances of being rehabilitated and reintegrated into the community was virtually zero. So they were basically warehoused. And all that was offered to them was the generic sort of forensic program. So you had all these ID patients scattered throughout the system, some with many other diagnoses, and no distinction, nothing special was done for them. They just had to cope. So if I looked at this on the balance, I suppose on the one hand, their basic needs were fulfilled. They had received food, their physical care, medical care was taken care of, and they were supervised. And in a sense, the forensic system in those days was a substitute for an absent welfare service. They all needed welfare, and this is what we provided them. But the disadvantages really did kind of outweigh it. For example, their specific special needs were not addressed, especially the criminogenic factors. And we were very concerned about sexual offenses. They were always vulnerable to abuse from other state patients, and the abuse usually was that they were being sodomized, they were roughly handled, they were denied access to things because other patients were bigger and more powerful. And really, there was just little hope of discharge. Even sending these patients out on long leaves of absence was a problem. Many of them lost contact with their families, their communities were impoverished, there was not good enough supervision. And the problem, as I said earlier on, is that many were young and destined to remain in the unit forever. That was the problem. And the following are just not appreciated with this group of patients. The first is that the criminal behaviors of patients with people with ID is often a symptom or due to the failure of a general welfare system. Now, I'm not talking about disability grants, I'm talking about services, housing, supervision, all sorts of things that perhaps in other countries are available to people for ID, they're not available to our patients. So it was easy for them to be charged with crimes, which obviously they didn't know what they were doing. We didn't really look at whether these people with ID had unique criminogenic needs. Was there something unique about this group? And in fact, if you look at surveys around the world, at least 10% of prisoners in prisons who've been convicted of crimes have an IQ of less than 70. So this is an enormous problem. And an unknown number of people with ID commit offenses, not just because they have ID, but because there's a combination or interaction of other disorders, particularly other psychiatric disorders like a bipolar disorder, a schizophrenia, a psychotic disorder, and of course, substance abuse. Substance abuse is an enormous problem. So where are we currently? In the last couple of years, we managed to open 48 beds at Alexandra Hospital, which many of you know is a residence for ID people. And Ms. Abbas, who has a particular interest in ID, has initiated programs or a program in those two wards. And her focus is really on sexual offenders. The OTs have been trying to improve their basic ADLs. And we've really been trying to strengthen ties with families, which I can tell you is an uphill battle because their families often are impoverished people who can't supervise, they can't give basic needs, they can't even ensure that the patients take their medication. So it's an uphill battle. But many of our ID, people with ID in the forensic units are scattered amongst other patients in other wards. And we don't even really know who they really are. We haven't done an audit yet. Most of these patients have become institutionalized, they've now aged, and they have chronic medical illnesses, other physical frailties. And our problem is that we do not have formal or any ties with the general ID population that I'm talking about in the service. So there's a service for people with ID at Alexandra and at Leinster. I'm not sure about Stickland, but we don't have ties with them, formal ties, which is a huge problem. Because what is happening is that people with ID who can't cope in the community are being reinstitutionalized by staff. Now, this is a chronic problem in the forensic unit, where people who cannot cope in the community because of a chronic problem or disorder are being charged with crimes, and they're being made chronic patients. And then, just as a general observation, the forensic mental health service is the new chronic system, and everyone is in denial about this. And where it is felt most acutely is with people with intellectual disability, because they have no hope of leaving the system. Once they've been charged with a crime and they've been made a state patient, they have absolutely no hope. So just looking at the database I have, and I found 65 patients, 65 state patients who have a formal diagnosis of ID. And I looked at the offenses with which they were charged, and it's quite striking. So assault is very important. Property crimes, not very important at all, like housebreaking, etc. But if you look at the sexual crimes, so there's attempted rape here, indecent assault, kidnapping and sodomy, there's rape, sexual assault. That is the predominant charge that ID people face in court. Second of all, do not forget these violent cases of murder and assault. So we have this sort of bimodal distribution of charges. It's not as though we are at a loss as to what to address. It's quite obvious just looking at this graph. The question is, what can be done? Like everything in mental health, there's no blueprint. We have to engage ourselves in an iterative process. And that is why I'm so pleased about this conference, because now we can start the conversation and start trying things. So for example, there really needs to be a change in legislation and new national policies to do with people with ID. There has been, I'm not going to discuss it now, but there has been some progress in the courts with the Stierman case, where basically if someone with ID is charged with a crime and is found not fit to stand trial, we have to think creatively, not just make them state patients. We should have to think of what their particular needs are. But linked to this are a whole group of ethical issues that need to be addressed, discussed, and I think we've been in denial. In fact, if you look at the United Convention of Disabilities and the Declaration of Hawaii, you're not supposed to deprive someone of their freedom because of a disability. We've actually signed those conventions, and here we are doing it. These people have a disability and they're being held against their will indefinitely. That's wrong. But I think it would go a long way if we formally created a dedicated forensic ID unit. We're making a start at Alexandra Hospital, but I do think this needs to be formalized with staff, specialized staffing, etc. And we need to focus on their special needs. For example, we need to look at risk management for aggression and violence and sexual offending. Go back to that graph. Those are our two major problems with people with ID who find their way into our system. We need to look very carefully at what their education and training needs are. And we need to aim for some degree of self-sufficiency in this population. Now just remember that many people with ID appear to be a lot worse or severe simply because they've had very little input in their early years. They've had very little training, very little education, very little stimulation. very little nurturance, etc. And if one gives a significant number of these people that sort of input, we may be able to improve their functioning, and it may be possible that they could live a much better quality of life, especially in the community. Another interesting but contentious issue is, well, can one attempt at a restoration of competence with these people? So the fact that they've become state patients means that we've assessed them as not being competent. They can't stand trial, and they can't enter into contracts, etc., etc. But maybe we do need to apply ourselves, particularly in a research sense, is can competence be somehow restored in these people, or at least to an acceptable degree so that they can live in the community? Which means that ultimately we have to find some sort of support and means to reintegrate people with ID back into the community. It's no good having a young person committed as a state patient where they're going to spend the rest of their lives in a closed ward with little hope. And believe me, our patients with ID feel hopeless, they feel desperate that they can't get back out of the hospital. So what conclusions can I offer you here? It's all about planning, really. So first of all, I think we should negotiate with the powers that be. I believe they're somewhere in Wells Street in town, and there's also powers that be somewhere in Pretoria in a very high building. I think we could negotiate with those people to provide us with a separate service for forensic ID. Because the problem right now is that we have 2 feet, one foot in ID service and 1 foot in the forensic mental health service. Somehow we need to bring those 2 together. Which means, of course, that we're going to have to lobby for policy and legislative changes. We have tried that process. Perhaps I'm hoping that Eva Malutsi speaks to that, because that's something close to her heart. We need to establish intersectoral links. People with ID in particular depend a lot on what's in the community, NGOs, mental health organizations, etc. And this has to be an iterative process. We have to have lots of talks. We should give more lectures on this. We need to do research. And I think we need to have hope. I think that's the most important aspect of all of this, is to have hope. And I thank you very much for inviting me. And I just hope this kickstarts a very important initiative in this field. Thank you.
Thank you very much, Professor Kaliski. I've noticed that there haven't been any questions submitted to our chat, and I'm not sure if there's a way in which we can see if there are any oral questions from the group so far.
I just think it's because whatever I say can't be challenged.
Yes, that's true, but there may be some comments from the participants. Is there a way in which current active participants can cue us that they have a question to ask?
Okay.
I don't notice any hands. Sean, I think that, there's a question from Dan Stein. Do you know of any country where they've achieved a little bit more success, where things are being managed a little bit better than it is locally?
United Kingdom. United Kingdom has a separate forensic ID service. In fact, they have a separate ID service altogether. And my understanding is that they have instituted quite a bit. The only other place I think that might have a good service would be New Zealand, because New Zealand has an excellent forensic mental health service. And I just have a memory that they that they have a good service.
Yes. So New Zealand and the UK, probably parts of Northern Europe as well.
No, surprisingly not. Northern Europe and a lot of Europe is actually quite backward with forensic health service. For example, France basically doesn't even have a forensic mental health service.
Yeah.
So it's a very complicated system. Japan, for example, has no forensic mental health service. And Sweden has a very strange service. Everyone's convicted and then referred as forensic patients under the Department of Justice and not the Department of Health. No, worldwide, there's not much being done.
Yeah. There's a question about how legislation, improved legislation, could assist the successful discharge and reintegration of offenders into the community.
That is a separate talk that I could regale you for an hour. But essentially, people with ID mostly are not fit to stand trial. And you don't get to criminal responsibility at all because they are unable to give you an adequate account. So the idea is that if somebody's not fit to stand trial, well, fitness to stand trial should be a very separate assessment to criminal responsibility, which they do in Canada, by the way. So in other words, they should first be referred for fitness to stand trial. And criminal responsibility should only be assessed if somebody is actually fit to stand trial. So if they're not fit to stand trial, they should be sent to a program where some sort of restoration of competence can be attempted. And that could take up to 6 months, whatever it is, and then there could be a decision to be made as to whether the trial proceeds. But having said that, I mean, the Stearman cases, etc., have made a good start where we have to provide alternatives to being certified as a state patient. The downside of that is that there are very, very few facilities in the community for people with ID that you can refer to.
Yeah.
It's the same with children and adolescents, by the way. So it's all very well having that as a procedure or a policy, but if you don't have the resources. So yeah, we've got to build resources up first.
Yes. Sean, there's a question about, given our resource constraints in some provinces, would it be possible to develop separate service rather than separate units? Maybe cross-provincial services as opposed to individual units?
It's a really interesting but difficult question. So if you have a national service, it means it would be centralized somewhere in the middle of the country. Unfortunately, that does not allow you to try the person out on leaves of absence in the care of family or other community resources. So that's a problem. So essentially, each province is going to have to develop some service. And it's going to be quite tricky. So they're either going to have to develop a separate service or it's going to have to be an ancillary service to whatever's existing. And it's going to be up to each province to work out. I think one should just regard each province in South Africa as a separate country with its own problems and its own resources and personnel and so on. And that's the nightmare that National Department of Health faces.
Yeah. Speaking about the National Department and these higher powers that you refer to in offices in West Streets and in Pretoria, to what extent is this information shared with those higher powers? And what, if any, programs have been initiated to prevent crime, particularly assault and rape, amongst this population?
No, National Department is very much aware of it. And in fact, Eva and I have been involved. We've actually done a presentation at, I forget the name of the department that changes the laws. A couple of years ago, we gave a presentation on how to change the law. And we thought that would be the first step. But National Department is very much involved. And well, I suppose they just have this general feeling of helplessness as well, because the problem for National Department is they're dealing with all these provinces with differing, resources, personnel. It's very, very hard. And that is why we've got to start talking and start working out a generic system that will work everywhere in the country and not just here or Gauteng, whatever it is. It's got to work everywhere.
Yes. There's a question about LOA for individuals forensic patients with forensic patients generically, if there are any particular challenges with providing access to LOA for individuals with intellectual disability, are there any specific obstacles for people with intellectual disability to access the same recourse to LOA?
Huge obstacles, huge. So most of these people with ID come from impoverished communities with families who are living in overcrowded conditions. There's often not enough food. And if the person with ID has to take medication, there's seldom anyone who administers the medication or supervises them. So on the one hand, there's a group of patients who we know we're sending them out to these conditions, and they really do come back worse. Poor self-care, relapsed if they had another disorder, all sorts of problems. But on the other hand, if you don't try all of this, you don't find out the many, many families and the many community resources that actually do work. You'd be quite surprised how many families out there who are impoverished, who have all sorts of obstacles, still manage to care for our patients very, very well and are very supportive and will visit and will participate in programs. So until you've tried these LOAs, particularly repeatedly, you won't know what you're dealing with. So you have to try people on LOA if you can.
Yeah. There's a question just referring to one of the points you made right at the start about how capacity or competence is linked to a very kind of categorical declaration about intellectual ability in terms of IQ, and
Yes.
how that excludes consideration around functional capacity and the way in which function can be supported and how it can be enhanced. Do you have any further comments to make?
Okay, so in our courts, there are two fallacies that are pursued relentlessly. The first is mental age. I don't know where this concept why it has endured, but you will still find psychologists, etc., presenting evidence in court that someone has a mental age of 6. Now, if you are really the age of 6, you can't be held criminally responsible for your actions. So if you have a mental age of 6, then you're not criminally responsible. It is the most ludicrous, absurd concept that is still propagated in our courts. The second is that measurement of an IQ somehow tells you how intelligent someone is. Well, it's not. IQ tests, in my view, are just not valid in South Africa. And it first gained my notice when we had a state patient who scored an IQ of about 35 or 40. And then we found out that he was a farm worker and he could drive a tractor. Now, a tractor is a very, very complicated piece of machinery. And he drove that tractor superbly well. And in fact, when you watched his function in the ward, it was really good. Why did he score so low? It was because IQ tests are not culture fair. The guy who's grown up in a rural area has no idea what these tasks are required of him in an IQ test. He's never had an experience of it. And yet he is very functional. And sometimes the language is very difficult. If someone grows up in a rural area with poor education, it might be quite difficult to understand them, but they might be still high functioning. And that's our problem, that we haven't focused on functioning rather than a score and a test. There's this frenzy in our profession for scales and tests and etc. And the idea that a clinician who gets to know someone really well is half as good as some score on a test. So if I say someone's not depressed, but a HAM-D says they've got a score of 24 or something, then they are depressed. So there are all these inconsistencies that need to be ironed out. Sorry about the sermon.
No, that's absolutely necessary. There's a question about the high crime rate and whether there's the political will to give forensic patients a second chance, that perhaps a kind of defensiveness against granting forensic patients liberty. I'm not sure exactly what the question means, but I suspect that perhaps in an atmosphere of overwhelming crime, that there may be a reluctance to extend freedom to to convicted, well, to forensic patients?
Actually, the research shows the converse. So in countries where there's a very, very low crime rate, and I refer to, say, countries like Canada and Northern Europe, etc., the contribution that people with psychiatric disorders make to violent crime is quite significant. And therefore, those communities, those countries have become very high risk averse to people with ID and psychiatric disorders with respect to crime. So they will keep those people locked up indefinitely. In our system, where we know that people, no matter what we do, they're going back to a toxic environment where there's high violence. And I think people just know that violence in our society is committed overwhelmingly by people who do not have ID, who do not have a psychiatric disorder. That in actual fact, I don't see any political will or surge of interest in keeping people with ID locked up indefinitely. In fact, we have no problem in sending people out on leave to the community, so long as there's someone to receive them and supervise them. We find no resistance whatsoever, except in those cases where someone is guilty of sexual offenses and they're going back to a family who live next door to a school. Then you start finding a bit of resistance, but that's the exception.
Yeah, there don't seem to be any more questions, Sean.
Sure.
Are there any final comments from you you might want to?
No, I'm just looking forward to the other speakers. I want to hear what other people have to say.
Thank you very much, Professor Kaliski. I wonder if our next speaker is available. It is Dr. Nagdee.
Hello, can you hear me, Peter?
Ah, great. Oh, hi. Hi. Dr. Nagdee, welcome.
Thank you.
It is an equally great pleasure for me to introduce Dr. Nagdee, who, like Professor Kaliski, perhaps needs very little introduction, especially to his colleagues in the community of forensic psychiatry in South Africa, where he has played a fairly prominent role over many years in research, in teaching, and also in service provision. Dr. Nagdee, until very recently, was the head of clinical services at Fort England Hospital in the Eastern Cape, where he also had an appointment as an associate professor in the Department of Psychiatry at the Walter Sisulu University. Sadly, Dr. Nagdee has moved to what he considers perhaps greener pastures, which is for him at the moment in Dunedin in New Zealand. And while we mourn his departure, we certainly wish him the best for his new appointment. Dr. Nagdee is going to be speaking with us. He's going to do the next presentation. He's going to be looking at offending behavior and intellectual disability. And the presentation will take the form of a review of criminogenic theories and evidence. Thank you very much, Dr. Nagdee.
Thank you so much. Thanks, Peter, and all the other organizers for the kind invitation and hosting this important conference, and also to the audience for participating. I do have one disclosure. It's this. I'll admit that it's really weird to be talking to an audience that I can't actually see. You're both invisible and muted. I'll assume that you're really there, and it's good to know that there's some old friends, perhaps some young friends in the audience. So thanks very much. So Sean has really expertly emphasized the importance of the broader context when it comes to the matters under discussion. And I hope to build on these themes. So the first thing is that ID and ID offending is, I think, all too often viewed through an oversimplified lens. And I'm hoping to highlight in this talk both the heterogeneity and the complexity and issues around individuality when it comes to ID offenders themselves, the offenses they commit, and the reasons and the broader context in which these offenses take place. So I'm going to go fairly quickly through some of these slides, and please forgive me if that's the case, but we can always come back to some of the issues. But the first is that the relationship between ID and offending is an incredibly complex one. The concept of crime is a complex issue. There's often sample bias in research studies. Generalizability of findings is a complex issue. The issues of standard diagnostic criteria and classification systems, the reliability of clinical records, ethical research issues, etc. Secondly, there's complexity around causality and what we mean by causality, whether it's direct or indirect, and this continuum of causality when it comes to this relationship. Stigma is another issue that adds complexity to this and weight to this particular discussion. And of course, as I think many speakers will emphasize, there's a paucity of research data in South Africa in particular. But as a summary, in general, the epidemiology of offending, we know, primarily, particularly violent offending committed by males. An early onset predicts a longer career. At least half of antisocial juveniles go on to become antisocial adults, and offenders tend to be versatile. So these are sort of known risk factors for general offending behavior. Similarly, core risk factors, early onset impulsivity, poor educational attainment, etc., as is listed there. So what I really want to do is look at some of these criminogenic theories. If you can't read that, that says early microbiologists, and there's a row of them peering through a petri dish with naked eyes. And I want to just look at some of these criminogenic theories and highlight really the complexity of the matter. So if we look at some of the genetic theories, various studies have been done. And as a summary, some of the conclusions, probably the most important is to choose your parents wisely. But they're really qualifications in respect of the relationship between genes and offending behavior. In respect of forensic ID, there's of course scant data. The second issue is that the strength of the relationship is variable. And the question is, what exactly is inherited? Heritability is of course a population rather than individual characteristic, and is not immutable either. Going on to sociological theories, there are a range of them. For example, the so-called delinquent conformity theory regarding impaired reasoning and verbal and social skills, and the development of poor capacity to delay gratification. The social control theory of offending, in which the learning of criminal behavior via positive association with negative influence is paramount. Social processes in the learning of crime and the development of so-called delinquent peer networks, and the importance of family and social circumstances in the genesis of subsequent criminality. In respect of ID, what can we conclude from such sociological studies? The first is that individuals with ID tend to have parents with ID themselves. Secondly, that they're more vulnerable themselves to manipulation. Impulsivity and risk-taking behavior is often a common issue, is a common issue. People are less likely to be gainfully employed and come from low socioeconomic backgrounds. So all these factors you'll hear being repeated as we go through some of the theories subsequently. And I'm hoping to draw all these into an integrated understanding as we go forward. What about so-called developmental theories? So some of these include ideas regarding the fact that so-called non-distressed or stable families reinforce pro-social behavior, and the opposite, where other families that are less stable or more dysfunctional may entrench coercive or even offending behavior. Social learning theories, the importance of relationships, particularly parent-child and peer-child or peer-peer relationships, and observational learning and modeling behavior, including offending behavior, is important. And as most parents with adolescents will tell you, the significant influence of schooling and teaches on adolescent behavior. So what can we conclude from these? The first is that many children with ID have parents with ID, and the dynamics of the family situation plays an important role in molding subsequent behavior. School disruption and peer group influences are particularly important, and a whole range of biopsychosocial factors are crucial, which we'll come to a bit later. So, for example, low frustration tolerance, poor verbal skills, cognitive rigidity, impulsivity, poor social competence, and comorbidity are just examples of some of these factors. So from peering at these theories from a distance, maybe we can graduate to developing a tool for having a more focused look at some of the issues at hand. That says it's a mammoth indeed, but perhaps we need to refine our lens somewhat in considering the epidemiology of ID offending. So a number of research approaches have been adopted, all of them fraught with some kind of difficulty. So the prevalence of ID in the criminal justice system, most studies based in police stations, courts, prisons, etc., are retrospective. There are significant difficulties with the use of definitions and classification systems across studies, and really clinical data in particular has poor reliability in such settings. What about the prevalence of offending in ID services? It really only includes, or studies around this only includes people that are known to those services. There are many people who engage in offending behavior that are unknown to services. And thirdly, population-based or criminological studies which seek to identify societal risk factors that predispose to offending. These are generally large and expensive, and data on ID offending in particular is really poor. But some of the conclusions of these criminal justice epidemiological studies include the following. So there are generally higher rates of arrest in studies that look at prevalence in police stations and such settings. In the courts, ID offenders make disproportionately more court appearances, in fact, have longer periods of arrest between their arrest and sentencing, and generally tend to come from more socioeconomically deprived settings. In prisons, up to 10%, in fact, of the prison population have IQs less than 70. And many of these retrospective early studies showed nil or perhaps only modestly increased offending by people with ID, although subsequent studies show that up to 4 times increased likelihood of criminal conviction by the age of 30 when it comes to people with ID. What about studies looking at ID services? Approximately 2 to 5% of people using ID services have had contact with the criminal justice system in the past year, although a minority are charged or convicted. And overall, there's a low overall rate of offending behavior, of course, amongst the known ID population. There's generally a high tolerance of alleged offenders, particularly those that commit less serious crimes. And if victims have ID as well, the crime is also less likely to be reported. There's some suggestion that patterns are changing, and the arrest net, for example, for ID offenders is widening, and that there are potentially increasing conviction rates in many countries around the world. So what about the profile of the ID offender within forensic ID services? As you know, this description is a typical ID offender, in inverted commas, young males with a borderline to upper mild ID range and with a background of deprivation, early onset behavioral problems, and comorbidity, particularly with respect to substance misuse, other mental health problems, personality disorder, autistic spectrum disorders, and the like. What about offending patterns? And here I think we are quite different in South Africa. Most of the studies are done abroad, but property and fire setting offences seem to predominate in many settings, including the UK, and crimes of personal violence in many of these studies are relatively low. But as I said, this is very different in settings like Southern Africa. When it comes to violent and sexual offences, though, there is a heterogeneity as well amongst this cohort in terms of risk factors, individual factors, and the nature of the offences that are committed. So what about the degree to which population-based studies predict offending behaviour? Most suggest that up to a third of those with ID are convicted by the age of 30, and a relatively small number of ID offences are responsible for a disproportionately large number of offences. And again, these predisposing factors are common to many of the studies that have emerged. So, how to summarize all of this in terms of the forensic ID population? The first, and again, it's the recurring theme, is the heterogeneity in terms of the context, the nature of the offending, and the clinical profile of the offenders. Those people with ID who are unknown to forensic ID services have generally borderline to upper mild levels of impairment and backgrounds of family dysfunction, childhood onset behavioral problems, comorbidities is the rule, and are generally engaged in less violent crimes that are often tolerated by families and the community. Whereas those that are known to forensic ID services where they exist, and indeed they do exist in a more established way in both the UK and in New Zealand, there tends to be a wider range of intellectual impairment, and due to the nature of the forensic system, the offending profile tends to involve more serious violence. So how do we put all this together? This cartoon is directed at us as mental health professionals, not people with ID, just so you know. So as you know, the process of theory knitting integrates the best parts of existing theories into a more comprehensive network. And a good example of this in the forensic ID field is a model that I'm going to adapt to try and draw this together, is the Integrated Theory of Sexual Offending by Ward and Beach in 2006. And I strongly recommend you look this up if you're interested. And we can use the typical biopsychosocial approach to causality with respect to both clinical consequences and offending outcomes, and adapt it to ID offending models. So if we do this, what we're really referring to is neurobiology and how a combination of neurobiological factors contribute to increasing the risk of offending behavior. So for example, problems with brain development secondary to birth trauma, genetic factors, neurohormonal factors, for example, testosterone or cortisol level and the influences on behavior, may cumulatively predispose to someone with ID to act more impulsively. If we add the so-called ecological niche to this, these, together with neurobiology, these are so-called static or historical risk factors. The ecological factors, probably the site of many or some of the most important risk factors in offending behavior. So besides these listed, they can also be categorized, I think, in quite a useful way into proximal or individual factors and more distal factors. So examples of the proximal factors include those that we've heard about in social control theory, for example, where the learning of criminal behavior via negative social influences and the poor development of self-control through appropriate learning is criminogenic in itself, as opposed to distal factors or early social experiences. So for example, poor parenting practices, early abuse experiences, limited family and social supports, and attachment and intimacy deficits combine together with biological factors in order to contribute to the criminogenesis and the culmination of offending behavior. The third aspect are neuropsychological or biological influences, and there are really three interlocking systems. The so-called midbrain limbic system of motivational and emotional factors. And if these are maladaptive in some way, then there's reduced motivation to act in prosocial ways, for example, in ID. Or people with ID may be vulnerable to seeking emotional gratification in inappropriate ways. Similarly, dysfunction in action selection and control, in other words, prefrontal systems, impairs the ability to form appropriate action plans and to achieve goals in a prosocial way. So, for example, this will include poor problem-solving skills, impulsive behavior, social disinhibition, and really poor regulation of behavior. And these factors will then contribute to the clinical picture. And of course, this is something that we're familiar with. Affective problems in ID, for example, poor emotional control, affective lability and negative mood states, social difficulties, sometimes overlooked in our medicalized model of care. So loneliness, social isolation, inadequacy, poor self-esteem in people with ID, and really importantly, some of the cognitive distortions that people with ID often exhibit. And it's easy to see, well, not easy to see, but it's, these are all linked to the genesis of offending. For example, gender-based violence or sexual offending. These cognitive distortions are sometimes perhaps underestimated in how they contribute to these outcomes. So in the end, all of these contribute cumulatively to the overall risk of offending. And offending is maintained and perhaps escalated by this cycle of biopsychosocial risk factors and how they impact on clinical status and how this results in offending outcomes. So in summary, I think these are some of the important legal and ethical concerns that I've tried to highlight, how we need to embrace heterogeneity and complexity, how we need to respect at the same time individuality in respect, with regards to individual IDs, offenders and their unique life stories, how we need to be aware of our own prejudices and stigma, and how we need to be informed. These principles, I think, will provide some guidance into answering some of these questions, which Sean highlighted and the discussion after his presentation emphasized. What is the situation in South Africa? How do we develop forensic ID services? So, for example, developing forensic ID units, and how do we incorporate resource-poor setting? How do we develop community-based forensic ID services? How do different ID service models influence care pathways and offending pathways? And what factors protect people with ID from engaging in crime? Thank you. I've realized that I perhaps have exceeded my time, so I think I'll stop there. Thank you very much.
Thank you very much, Dr. Nagdee. I'm just watching for any questions. It was a very comprehensive presentation, and I liked the way in which you captured several of the interacting factors on one of those grids, in which you you took a biopsychosocial contextual approach, which is something we often apply. One of the sort of general difficulties we confront in the clinical setting, particularly in the non-forensic setting, is the combination of vulnerability and dangerousness, how those can operate simultaneously in an individual with intellectual disability. Do you have any comment about how one ought to negotiate that very thorny combination?
Yeah, I think this highlights the complexity, doesn't it? On the one hand, people with ID are often, for a range of reasons, vulnerable themselves. So I think that's a default setting, really, in respect of ID, people with ID. There's a degree of vulnerability that is a given. On the other hand, and perhaps a bit counterintuitively in that respect, it is also many of the factors that lead to the vulnerability that contribute to offending behavior. So there's a commonality, there's an overlap that generates vulnerability on the one hand and a predisposition to behaving or acting or making choices that lead them on offending pathways. And, I think all too often, I think Sean mentioned at one point that in certain settings that the culture is so risk averse that the emphasis really is on the latter, in other words, on offending outcomes, as opposed to looking at the vulnerabilities and looking at the contributions that the nature of the ID and the context in which it grows and evolves has contributed to those outcomes. We can't look at offending behavior in isolation. Looking at offending outcomes by themselves does little to address the vulnerability and address this complex cycle that you referred to.
I'm not noticing any other questions. There's just a comment about you, as I said, sort of supporting my view that you've really managed a very complex area in a very bracing and thought-provoking way. But the comment revolves around what you think can be mobilized in the community to operate as protective factors or as risk mitigating factors, I think particularly in our context.
Right. So again, these are huge questions, aren't they? I mean, protective factors in preventing criminal behavior and people with ID in the community. I mean, we can talk at length about this. Sean mentioned that what is essential is looking at services within communities. So, establishing and developing a community-based mental health system, firstly, because it's rudimentary at best in many of our provinces, would be a start. But we really need to evolve beyond that. We need to look at establishing a forensic ID service, firstly, but as an extension of that, forensic units, whether they are provincial or national medium secure unit, for example, will have to be supported by community-based forensic ID services. Now, this sounds like a ludicrous proposition, given our context, but it has been done in other countries quite successfully. I worked in the UK, for example, for a few years in the forensic ID service, and they had an interesting system. They had a national medium secure forensic unit, only one in the country, and then smaller, low secure forensic units. But the forensic community-based ID service was coordinated from the national unit. So it was essentially a single community-based service that was coordinated from a central point. These are models that I think we should be looking at. Without community-based forensic monitoring and without community-based mental health support, in addition to community-based social services, family support services, I think it's very difficult to prevent offending and prevent criminal behavior.
Indeed.
Yeah,
in fact, there are two comments that revolve exactly around that point, and it is about prevention. And are there any interventions that you can suggest that could be effective in altering the trajectories of people with these developmental vulnerabilities to prevent pathways into offending behavior?
Yeah. So I think, for a start, in terms of our forensic system, I think Sean again touched on this. I think we need to be looking at people with forensic ID through a different lens. In the end, if we continue to base our forensic system on institutional care, I think we'll struggle to develop services further. We have to change our models of care. We have to try people on leaves of absence, and we have to work towards true community-based rehabilitation. I think that's the first thing we need to look at in terms of the existing forensic services we have. Developing a forensic ID service is in many ways a much bigger task, because without family-based, socially based and community-based services, I think rehabilitation outside or extracurricular rehabilitation, I think is unlikely to succeed. So, I'm reiterating the same points, but I think all services in which they've got a fairly well-established forensic ID services emphasize this point. And in New Zealand, I found the forensic ID service, I'm working partly in one at the moment, is not as well established as the UK, but certainly the community-based forensic system interfaces with the forensic institutional ID system in a way that I think needs to be looked at in developing services in South Africa.
I think there are questions exactly about that point, about the relationship between the non-forensic or the generic ID services and the forensic, because often one confronts very similar behavior. For example, sexually offending behavior amongst non-forensic people with intellectual disability in generic or general psychiatric units, how one manages that. And oftentimes we'll have in the generic services individuals who struggle to access the forensic service in a way because they've already been captured within the generic service. And so I agree that those links need to be articulated a little bit more seamlessly than currently.
Right, and I'll just add to that, Peter, I don't want to create the impression that, for example, here in New Zealand, that things work seamlessly. They certainly don't. In the unit that I work in, they have a similar problem where it's a unit in which there's a mixture of so-called general ID patients and forensic ID patients. And in many ways, the organizational structure doesn't allow clear demarcation of who's responsible for the care of these respective cohorts. And there's often bun fights about, care pathways and exactly who takes responsibility for these different cohorts of patients. So it's still very much a work in progress, but I think we can learn from some of these models.
Yeah. I'm just a little anxious about the time. In fact, I think we do have time for one or two more questions. There was a question about vulnerability and how that might be aggravated by gaps, both in health services, but also broad social gaps, and how that might be ameliorated. To some extent, it is addressed in your grid, but are there any comments you want to make specifically about how vulnerability or vulnerability can be ameliorated by attending to those gaps?
Yeah, so I think we need to be more proactive in destigmatizing ID and people with ID in general. I think that there's a long way to go in our setting, both within general South African society, but also within health services, within mental health services, and in fact within forensic mental health services as well. I think we are riddled with prejudice and stigma. We are often dismissive. We all too often hear suggestions that this is just another, ID offender who's got horrific sexual offending charges against them, and our approach needs to be a more nuanced and less stigmatizing. So I think if we start there, and that has to be a non-negotiable departure point. For me, without that, if we don't change our own mindset, I'm not sure how we can start influencing those in society, in broader society, and how to fill these gaps. Vulnerability is often as a result of stigma and prejudice, in my view.
Yes, indeed. There are comments as well about the roles of the other services, education, social development, etc., that can offer preemptive interventions as to prevent final access to forensics as the definitive intervention. Thank you very much, Dr. Nagdee, and there may be additional questions. I'm quite sure that you would be willing to receive them and respond to them later for people to access. But once again, thank you very much for coming on board and for your presentation. Thank you.
Thank you. Thanks for the invitation. Thanks for listening.
Thank you. I think we've reached the point in our program where we have a tea break. Sadly, this is going to have to be a tea break by remote, and probably you'll have to provide your own tea. And we resume our program at 9:55, but in the meanwhile, there will be a patient art display, which I imagine will be done electronically. So we reconvene at a 5 to 10. Thank you very much.
Hi, Nikita. Nikita? I have. Is it not sharing? Nikita?